Good morning, everybody. Thank you for joining us for today's webinar on trauma and violence-informed care related to STBBIs, supporting trauma and violence-informed practice and policy. For your information, all participants' microphones are muted today. If you have any questions you would like to be addressed after the presentation, please use the Q&A box that's located in your Zoom taskbar at the bottom of your Zoom window. The chat box is also available if you have any comments or technical questions. My name is Savannah Holt. My pronouns are she and her, and I'm the Sexual and Reproductive Health Program Coordinator with the Saskatchewan Prevention Institute. The Prevention Institute is a provincial nonprofit organization that's located in Saskatoon on Treaty 6 territory and the homeland of the Métis Nation. Our organizational focus is to reduce disabling conditions in children using primary prevention methods. We raise awareness by providing training, information, and resources based on current best evidence. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We work in a variety of areas, including fetal alcohol spectrum disorder prevention, maternal and infant health, early childhood mental health, child injury prevention, child traffic safety, parenting, and sexual and reproductive health. One focus of the Sexual and Reproductive Health Program is to provide evidence-based information on sexual and reproductive health that is accessible to healthcare practitioners and allied health professionals. Saskatchewan has high rates of sexually transmitted and blood-borne infections. Incorporating trauma and violence-informed care into our practices can be a powerful means of creating safer and more accessible spaces, combating stigma, and ensuring positive experiences that can contribute to ongoing access to preventative care and treatment. It is now my pleasure to introduce our speakers for today, Rachel McLean and Laura Bouchard from the Canadian Public Health Association. Rachel McLean, pronouns she, her, is a senior project officer with the Canadian Public Health Association, where she manages various training and education initiatives related to sexual health, harm reduction, healthy relationships, and stigma reduction. Rachel holds a Master of Public Health with a concentration in health promotion from the University of Toronto and has been working in the field of sexual health for several years in various capacities, including education, policy, and community engagement. She's passionate and dedicated to working with others to advance healthy sexuality and sexual rights for all in Canada. Laura Bouchard, she, her, holds a Bachelor of Arts in Psychology from the University of Ottawa and a Master of Science in Psychology from Trent University, where she concentrated on issues of sexual communication and social psychology. Laura's current work with the Canadian Public Health Association focuses on creating professional development training and tools for health and social service providers to address stigma and discrimination in relation to sexually transmitted and blood-borne infections, sexual health, and harm reduction services. Laura is passionate about social justice and sexual health and well-being, and is deeply grateful for the opportunities she has been afforded to learn from and work together with folks from across the country to promote healthy sexuality and relationships for all. Thank you both for joining us today.
Thanks so much, Savannah, for the introduction and for the opportunity to present today. As was mentioned, my name is Rachel and I use she, her pronouns. My colleague Laura and I are going to be discussing a toolkit that was developed by the Canadian Public Health Association. And this toolkit's focused on, as Savannah mentioned, trauma and violence-informed care. And so to start off today's session, we're going to provide a really high-level overview of trauma and of the principles of trauma and violence-informed care. But we will spend the majority of our time talking about the toolkit. We do hope that this session is, as practical as possible for everyone in the room today. So we do have a lot of information to share, but we will do our best to make sure that the session is interactive and engaging. We'll have a few activities using both the poll function and also the chat function. And we'll also try and certainly save some time at the end of today's presentation for questions and discussions. And I know there was a comment about, or a question about whether or not we can share the slides, so we can certainly do that after today's presentation. So before we begin, I do want to caution folks that talking about trauma and related violence can be upsetting, and that this is a completely normal reaction to these types of discussions for a variety of reasons. We encourage you to take care of yourselves, whether that means stepping away from your screens if needed, or moving your body in a way that feels comfortable. So before we begin, I do want to acknowledge that CPHA's office, which is in Ottawa, Ontario, is located on the original unceded territory of the Algonquin Anishinaabe people, who have been guardians of this land for millennia. CPHA is grateful for the example their stewardship provides, and certainly I'm grateful for the opportunity to gather and learn on this land. So we just encourage you to take a minute to reflect and thank those, and just think about the traditional territory from which you are joining today. So before we start talking about trauma and violence-informed care, or TVIC, it's important that we begin with a common understanding of trauma. So a lot of you, I'm sure, in the room are very familiar with trauma, as well as trauma and violence-informed care. So we're just going to provide a very high-level overview. There's, of course, a whole body of research and work exploring the prevalence of trauma, as well as the impacts of trauma on our health and well-being. And so we're just going to share a few key points that I think are important to keep in mind. Very simply put, trauma can be defined as experiences that overwhelm an individual's capacity to cope. And these experiences are most often marked by a loss of power and a loss of control. And so when we think about trauma in this way, it's really easy to recognize that traumatic experiences are very common in our society. So of course, experiences of trauma will vary depending on their source, be the source interpersonal or external, and also depending on the severity of the experience. We can also think about trauma in terms of frequency and duration. So people may experience a single traumatic event, like an accident or the death of a loved one, or they may be exposed to trauma over several years. So this could include, for example, experiences of war or intimate partner violence. We also know that folks can experience trauma over multiple generations. So this would include ongoing experiences of racism or colonialism, for example, and this would result in intergenerational trauma. So what I hope most resonates with folks today is that what a person defines as a traumatic event, as well as how an individual responds to a traumatic event or experience, will vary from person to person, and that there's no right or wrong way to deal with trauma. So some of you may be familiar with the term trauma-informed care. And so the term trauma and violence-informed care really represents an extension of trauma-informed care. So similar to trauma-informed care, TVIC does not focus on encouraging clients or patients to disclose details of trauma or on treating their trauma symptoms, as is the case with trauma-specific services. Instead, TVIC really focuses on fostering an environment where all clients and patients feel safe, and where there's less possibility that they'll be re-traumatized or traumatized. TVIC is also slightly broader in scope than trauma-informed care, in that it recognizes the connections between experiences of trauma and interpersonal as well as structural violence. So we know that structural inequities, and so what I mean by that is things like racism, different forms of oppression like classism, ableism, homophobia, transphobia, can create environments where violence and trauma are more likely to occur, and also environments where support and trauma-specific services are often more difficult to access for some communities. So when we think about trauma, it's also important that we recognize that ongoing experiences of structural violence and oppression, and again, I mean, experiences of homophobia or racism or classism and ableism, colonialism, these should be considered as traumatic experiences, and that these experiences will impact health and well-being, as well as how people engage with health and social services. So why are we talking about trauma and violence-informed care today? So earlier I defined trauma as experiences that are often marked by a loss of power and control. So one of the key tenets of TVIC is the need for universal application, meaning that TVIC should be integrated into all service settings with all patients, clients, and service users, irrespective of their trauma history and also or our awareness of their history. So if you take a minute to just reflect on the service settings that you work in, There are a lot of folks joining today. So whether you're working in general healthcare or public health services, or even more specialized services, it's likely quite easy to imagine the ways in which our systems can at times disempower those accessing our services. So TVIC is about recognizing that anyone that walks through the door of our services, or perhaps in the current context, anyone that engages with our services, even virtually, may have experienced or currently be experiencing trauma. And so TVIC is, of course, particularly relevant given the current context of COVID-19 and also ongoing anti-Black and anti-Indigenous racism. A large majority of our population is currently experiencing more stress and potentially trauma in relation to COVID-19 and anti-Black and anti-Indigenous racism. So the relevance of TVIC cannot be overstated given the many public health crises that we're facing today. And I think what's really great about TVIC, and hopefully this comes through over the course of our presentation today, is that it really does provide a more systematic way of disrupting some of the dominant power differentials that often exist between professionals and those accessing programming and services, and giving power and control back to clients and patients and service users.
Okay, thanks so much, Rachel, for that really great overview on trauma and violence-informed care. So moving forward to kind of when we think about how we actually put TVIC into practice, there's 4 main principles to consider. So these 4 principles that you see on this slide have been pulled from the BC Mental Health and Substance Use Planning Council Practice Guide, which is referenced on the slide. It is possible you may have come across slightly different language and other resources or literature sources to describe the principles, but for the most part, they're more or less the same spirit behind these principles in different sources. So these 4 principles, that is trauma awareness, emphasis on safety and trust, opportunities for choice, collaboration, and connection, and building on strengths and skills, provide a framework for service providers to actually integrate TVIC into their work. And again, what's most important is that TVIC is applied universally to everybody that engages with your organization, into every interaction between frontline service providers and clients or patients, and also into the ways in which organizations actually develop and implement policies and programming. So we are going to take a few minutes to talk through each principle. And a lot of the strategies that I'm going to be highlighting will likely already be familiar to many of you and in line with ways that you're already working. TVIC is very consistent with other frameworks that might already be guiding our work, such as harm reduction, cultural safety, and patient-centered care, to name just a few. So the first principle is trauma awareness. And without a sound understanding of trauma, it's possible for our relational approaches, as well as our organizational policies and programming, to unintentionally traumatize or even re-traumatize those who are engaging in our services. So for example, we might unintentionally interpret an individual's reaction to a situation as unwarranted or as hostile without actually first considering how past or ongoing experiences of trauma might be contributing to how they're reacting. So for this reason, it's really important that all staff within the organization understand the potential physical, behavioral, psychological, and spiritual impacts of trauma, as well as different ways in which individuals might react if they're traumatized or re-traumatized within our settings. And another important aspect of trauma awareness is that staff should understand potential signs and impacts of vicarious or secondary trauma, so that self-care and support for colleagues is also prioritized. The trauma awareness needs to be embedded into the organizational culture. So training should be offered on an ongoing basis, and trauma awareness can also be embedded into the organizational culture through avoiding punitive policies and procedures. The second principle is focused on creating environments wherein safety and trustworthiness are prioritized. So as was mentioned earlier, trauma can be thought of as an experience wherein someone loses their sense of control or safety. And these experiences can violate our sense that the world is a safe place or that people can be trusted. And so for this reason, it's important that those engaging in services feel safe and empowered at all times. By the very nature of our role as public health professionals, there's often an inherent power imbalance between us and those who are engaging in our services. So as a result, it's also important that professionals and providers continuously reflect on their own power and privilege. So in terms of safety and trust, at the relational level, this principle can look like communicating in non-judgmental ways and using inclusive language. It might also include explaining why it's necessary to discuss potentially sensitive topics, or preparing clients for appointments by letting them know in advance what to expect. At the organizational level, this might mean ensuring that intake processes are non-invasive. For example, not requiring people to retell their stories over and over again to different service providers, or that organizational policies clearly outline and uphold client or patient rights to confidentiality. And the third principle focuses on creating opportunities for choice, collaboration, and connection. And there are a lot of different ways this can be done, both at the practice and at the organizational level. So when interacting with clients or patients, service users should be provided with non-biased information about various programming, service, or treatment options, and the ability to execute agency in their own lives. At the organizational level, different agencies can connect and collaborate with one another. It's unlikely that any one organization is ever going to be able to offer everything that an individual might need in the way of programming or services. So for this reason, it's important that organizations connect with one another to provide safe referrals, for example, for trauma-specific services or for culturally specific services. Okay, so trauma experiences are often characterized by feelings of loss of control or power. Sorry, wrong one. So TVIC is a strengths-based approach, and so we're always working from the perspective that people in communities who've dealt with trauma, oppression, and violence have great resilience, skills, and potential to cope. So the fourth and final principle focuses on recognizing and building on the strengths and skills of folks who are engaging in your services as a means of promoting positive coping mechanisms and resilience. And this might mean helping clients or patients recognize their strengths and skills during conversations with them, such as by tapping into what a person's already doing that's helping them to cope, or discovering who their natural supports are. At the organizational level, this might look like developing policies and programming that are reflective of individual and community strengths.
Okay, thanks, Laura, for that overview of trauma and violence-informed care. So the toolkit that we're going to be speaking about really shortly was developed as a complementary tool for training related to TVIC that CPHA, in collaboration with the Center for Sexuality, launched in 2020. So the training that we co-developed with the Center for Sexuality is a 6-hour training. It was originally meant to be delivered in person, though it could certainly be adapted for online delivery. And it focused on the integration of TVIC at both practice and organizational levels. So in order to support other organizations in delivering this training in their respective communities, we developed some turnkey workshop materials. So this includes a facilitation manual, a participant workbook, and a slide deck. So essentially anything that somebody might need in order to deliver the training in their own community. And so these turnkey tools are available for free on CPHA's website. And so you can certainly, if you go to the link on the slide, and we will share these slides so that you can click on the links. So if you go to the link on the slide, you can learn more about how to access the tools. I'll also share both mine and Laura's email address at the end of today's presentation. So you can also connect with us if you'd like to learn more about potentially offering some TVIC related training in your own community. So in terms of developing the training, our first step was conducting a scan of the peer-reviewed and gray literature, and also conducting 4 key informant interviews with experts in trauma-informed care. And so these were done in the spring and summer of 2017. And the purpose of this initial scan was really to get a better sense of the application of TVIC to issues of sexual health, harm reduction, and STBBIs, and particularly in the context of service settings that are not providing trauma-specific care. So based off, some of the findings from this scan, the workshop content was developed with Center for Sexuality. And then between November 2017 and December 2018, we conducted a total of 12 pilot groups with 370 health and social service providers and professionals from 5 different provinces and territories. So this included nurses, social workers, pharmacists, physicians, health educators, health promoters, etc. So as part of the pilot testing, all the workshop participants were asked to complete a pre and post workshop questionnaire. And this was really to help us get a better sense of short-term outcomes like changes in knowledge and capacity and comfort related to TVIC. Some participants also completed a 6-month follow-up survey, and that was really to help us get a better sense of longer-term changes in behaviors, as well as organizational policies and procedures. And so, of course, based off the evaluation findings, a lot of revisions were made throughout the course of pilot testing to make sure that the content was reflective of the learning needs of health and social service professionals from across the country. And then the last thing we did was in the fall of 2018, we partnered with 3 organizations in Yukon, British Columbia, and Alberta to conduct focus groups with individuals with lived and living experience accessing sexual health and harm reduction services in Canada. So the purpose of these focus groups was to gather feedback and insight from folks with living experience. And specifically, we asked focus group participants to review some of the workshop content. So they had a chance to look at the workbooks, some of the case scenarios, and some components of an organizational assessment tool that we'll be chatting about briefly, and to identify needed revisions. And we also asked focus group participants to share their thoughts on how best to make services safer and more inclusive in Canada, particularly in the context of trauma and the potential for re-traumatization within service settings. So there were 5 key themes that emerged from these focus groups. And I think probably for a lot of you joining today, the themes that came out probably are not surprising and maybe reflective of things you've heard from, those accessing your services. For the first theme, participants spoke to the importance of being seen as an individual rather than a number or a stereotype. So one of the things that was echoed by many participants was the need for understanding among professionals of the individual nature of trauma, and sort of the recognition that there's no right or wrong way to respond to a traumatic event or experience. The second theme related to the institutional feeling of many health and social service settings. So several participants shared, different components or different sort of practices within health and social service settings that really contributed to feelings of powerlessness and loss of control. So for example, participants shared that having to wait a long time in a cold or sterile waiting room, or having to speak to somebody behind a glass wall, really could serve to sort of disempower and the whole experience for them. So on a more positive note, many participants did share that, when service settings used relaxing colors and murals or aromatherapy, and when service settings reflected the diverse communities and cultures of those accessing services, that this whole experience could be very empowering for them. So as part of the third theme, participants expressed their desire for their service providers to be more vulnerable, open, transparent, and compassionate, so that they could develop a trusting relationship with them over the long term. So no surprise, participants also expressed their desire to be seen by a consistent provider, so that they didn't have to tell the same potentially traumatic story, time and time again. And they also expressed a desire for better coordination between referral agencies. The fourth theme really relates to the workshop content. Participants were asked to reflect on the degree to which they felt represented in the workshop images, case scenarios, and discussions. And so overall, we did find that folks felt well represented, though we did receive some specific feedback regarding some of the images used in the workshop content and the need for better inclusion of specific communities. And so, of course, several changes were made in response to our findings from these focus groups. And so the fifth and final theme is really reflective of the need for a comprehensive approach when it comes to TVIC. And I hope this is something that comes across again throughout today's session. So focus group participants agreed that service providers need training, but they also shared that, their insights, and they felt that service providers needed more exposure to folks with lived experience of, related issues. So experiences of substance use and STBBIs and trauma and incarceration, for example. And they also expressed that a whole facility approach is needed.
Okay, so on this note that training on its own is not really a complete solution, we did endeavor to create a toolkit to complement the workshop that really focuses on tools that can assist providers and organizations to integrate TVIC into their work in a more sustained and ongoing way. So the toolkit that we're going to be spending the rest of the webinar talking about was released in January of 2020, and it can be used either alongside the workshop or as a standalone tool. And it's comprised of 3 separate tools, which include a provider self-reflection tool, an organizational assessment tool, and a monitoring and evaluation tool. And so together, this entire toolkit is meant to assist providers and organizations to integrate TVIC into their work. And just a quick note about how we adapted this toolkit, or how we created this toolkit. It was really drawn on similar existing resources, which you'll find referenced within the toolkit itself. And a lot of the existing resources we found were really developed for kind of more trauma-specific services, such as women's shelters, mental health services. And we wanted to create something that would be applicable to the broad range of service settings that might be providing STBBI, sexual health, harm reduction related services. So you'll find the examples in the toolkit really focus on sexual health and substance use, but many of the key strategies and principles found within these tools are applicable to a broad range of public health programming and services. You can download this tool from CPHA's website using the link on the slides, and it's available in both English and French. And we're going to be going through the sections of this tool for the remainder of today's webinar. So as mentioned, the first component of the toolkit is a provider self-reflection tool. And this tool consists of 17 self-reflection questions that are meant to help health and social service providers and professionals conduct a self-assessment of their knowledge and attitudes, skills and practice, personal feelings and experiences, and actions and intentions. So we've pulled out a few of the reflection questions from this tool, and we're going to be asking you to respond to these prompts using the poll function and by sharing some of your thoughts and strategies in the chat box. So thinking about your answers to each of these questions will hopefully reveal where you can set some personal goals to align your practice with the principles of TVIC. And within the TVIC toolkit, there's actually a page where you can record these goals. But as mentioned, we're going to be going through a few of these using the poll function. Okay, so we'll open the first poll here. And how this is going to work is once you've responded to the question using the poll function, and while we're waiting for the group to kind of collect the whole group's response, you can also share any reflections or responses you have to the second question on the screen in the chat box. So the question for the poll is, do I regularly review and reflect on my own attitudes, values, and beliefs related to trauma, sexuality, and substance use? For example, reflecting on assumptions I might have about people who've been through trauma, how they recover from it, ways they might cope. And then in the chat, we invite you to reflect on or to share some examples of some ways that you actually do build this regular self-reflection into your practice or into your regular routine. Should we shut down the poll now, maybe, Rachel? Okay, so it looks like for the most part, people are saying yes. Often this is something that we do already, already doing. And then I can see there's been quite a few responses coming in through the chat. So maybe let's take a quick peek at that. As a social work student, it's a regular part of all assignments in most classes. Yeah. Attending webinars when we can as a reminder to keep learning. That's great. Pausing before I respond when I'm unsure of something or when a situation is escalating. I think that's really great advice. Self-awareness, regular journaling, self-reflection and consultations, and when completing case notes, daily meditation and reflection of my day. Oh, this is fantastic. Oh my goodness, there's so many. I don't think we're going to be able to get through them all, but thank you so much, everyone, for sharing. I think these are really, really great examples, and it's really encouraging to know and to hear that this is something that folks are already kind of incorporating into their practice and reflecting on regularly. So debriefing with colleagues. Yeah, thanks. Feel free to keep those going in the chat, folks. I think for the sake of time, we'll move on to the next question, but this is fantastic. And there's clearly a lot of expertise in this room as far as TVIC. Okay, so the poll question number 2, am I comfortable using various grounding techniques with clients who might be re-traumatized in my care. Give just a couple more seconds for folks to finish responding. Okay, this one a little bit more varied, and I think this is a tricky one, and I think it's something that, depending on the nature of our role and the kinds of services that we provide, we might be more or less kind of familiar with or aware of or in tune to. Yeah, so I think an extension of this is also maybe being prepared with resources or referrals for trauma-specific services if someone does disclose that they're experiencing trauma and violence in our care, and also making sure that those referrals are appropriate for the person that's seeking them. For example, are they culturally safe? Are they LGBTQ2S+ friendly? Definitely feel free in the chat if you have some grounding techniques that you are really a fan of, or any resources that you'd like to share. Feel free to keep that going as well. But this is one that we really wanted to highlight and include, because I think it connects to the idea that we need to understand that healthcare and social service settings really are places where traumatic experiences can occur. For example, it could be exposure to racism or transphobia or HIV stigma when they're accessing services. And they can also be places where early experiences of trauma and abuse can be kind of triggered or brought back up. And so physical exams are one area where there's particular potential to cause re-traumatization. And on that note, we're going to take just a quick aside here to talk about another resource that's available from CPHA. So physical exams, they can be an opportunity to establish trust and reinforce a sentiment of care between providers and patients, but they can also expose patients to shame, vulnerability, or re-traumatization. So for example, the vast majority of patients have negative reactions to pelvic speculum exams, and nearly half of adult survivors of childhood sexual abuse report that pelvic exams trigger memories of prior abuse. So physical examinations of any kind, not only those that are seen as sensitive, such as pelvic exams, can similarly bring up past experiences of abuse or violence, or otherwise cause distress or discomfort for people of any gender. So this resource was created in partnership with Dr. Sadie Elisu, based on a framework that she developed for med students. And it really provides recommendations to reduce potential for re-traumatization during physical exams, and also STBBI testing or other kind of physical procedures. And this includes both language recommendations to increase feelings of trust, safety, and control, and also more sort of procedural recommendations. For example, letting patients know what clothing they can keep on, and being aware of personal space and how you position yourself. So that's a resource that you're definitely welcome and encouraged to check out.
Okay, so we're going to share another poll question here. So the question here is, do I feel at ease when talking to clients about sexuality, trauma, substance use, and harm reduction? Can I have these discussions using TVIC informed approaches? So as you are responding, or once you finish responding, we also invite you to share some of your responses in the chat. So what are some specific strategies or approaches you take to integrate TVIC into your conversations with clients, patients, service users? So, So we'll end the poll there and I'll share the results. So it looks like a lot of you are responding often. So about 43% of you feel that you're, often comfortable talking about sexuality, trauma, substance use, and harm reduction. And some of you are responding sometimes and always. And I think that diversity is probably reflective of, some of you may be having these conversations, multiple times a day. And for some of you, it might be a more irregular occurrence. And so thank you for taking the time to respond to that poll with honesty. And I see a lot of you are sharing some really great ideas in the poll. And some of these are really simple and, like to Laura's earlier point, reflective of other frameworks like harm reduction or client-centered care. So a lot of you are sharing active listening, asking permission. That's huge in terms of providing power and control back to folks. The use of person-first language, so important. Focus on using non-judgmental and empathetic approaches. And really just honoring folks when they do choose to share with us as professionals. Listening to music of the client's choice, I think that's great. Having a safe space, using open dialogue. There are so many. I think in the interest of time, I'll move on. But I think perhaps what we can do is compile some of the feedback that we've received through the chat and then share it back with all of the participants today alongside the slides, because there really are some really great strategies and some very specific ones that I think could easily be integrated. And so I know one that's come up and that we often share in our discussions is also letting clients, patients know how long you have for the appointment or what opportunities there are for follow-up, so that they can make an informed decision about what they want to share with you during that appointment or what they perhaps want to save for a future appointment. So as a follow-up to that last poll question, I do want to draw your attention to CPHA's Language Matters tool, which was released in late 2019. So I don't think this will come as a surprise to anyone today, but research has shown that the words we use to describe someone can influence our attitudes, beliefs, and behaviors towards them. And this, of course, extends to the care decisions that are made by health and social service providers. So this tool offers some general tips as well as some specific examples of respectful and inclusive language that can be used when discussing sexuality, relationships, substance use, and population groups. I know a few of you shared in the chat, the use of person-first language. And so certainly there are some specific examples of person-first language within the tool. It was developed in consultation with both professionals and organizations from across the country, and also reviewed by folks with lived and living experience. And so again, although the focus is on sexual health and harm reduction, there is a relevance to a broad range of health, social service, and public health programming and services. So I do want to mention and sort of caution, this tool is a helpful starting place, but our understanding of respectful and inclusive language should evolve as societal views change, and as individuals and communities choose to redefine their own identities. So the degree to which language is respectful and inclusive should be defined by the particular group. And so again, this tool is a great starting place, but please do engage with the communities you're serving in terms of identifying respectful and inclusive language. So it is available on our website, so you will have access to these slides to be able to check out that link. Okay, and so our last poll question I'll bring up now relates to, do I prioritize taking care of myself so that I can manage my own feelings resulting from personal or my clients' experiences of trauma and violence? So as Laura mentioned, one of the key principles of TVIC is also taking care of ourselves as professionals to reduce experiences of vicarious trauma or burnout. And so as you are sort of finishing up responding to the poll, we do also invite you to share in the chat what activities or surroundings help you feel relaxed and re-energized. Okay, so I see taking a hike is my church. Angela, I'm right there with you, even when it's cold outside. Lots of folks walking my dog, art, music, yoga, external support. That's super important to really understanding where our natural supports are. And of course, that can be more and more of a challenge in light of COVID-19, but figuring out how to still take care of ourselves. Face masks and self-care podcasts, cultural practices, smudging and praying, cuddling with my babies, taking a holiday, cooking good food, quiet time, ensuring that we engage in this daily, taking a bath, cleaning your office space. So lots of really great strategies shared. So thank you for that. I encourage you to keep going. I think there's something really uplifting about having folks share some of the strategies they use for self-care. And, we did want to end the poll on a positive note, because part of TVIC really is about taking care of ourselves as well, particularly with everything that's going on right now. So thank you, everyone. And as I said, we will share some of the responses in the chat with all participants. Okay, so we've talked a lot about the importance of training when it comes to TVIC, and I think you're probably all in agreement in terms of the importance of training, given your willingness to spend an hour with us this morning. So while we know training is important, in order to see true change in terms of making our services safer and more inclusive for our clients, we also need to think about the culture of the organizations within which we work. I do want to add the caveat that this can be really challenging depending on the nature of the organizations within which we work and the ease with which changes can be made. So Laura is going to provide a pretty high-level overview of the next section of the toolkit, which of course is the organizational assessment tool. And so by sharing the tool, we do hope that you'll be able to identify some possible changes within your organizations to hopefully move the pendulum more and more towards trauma and violence-informed care, and really just recognizing that this, for all organizations, is an ongoing and iterative process.
Thanks, Rachel. So as mentioned, the second tool within the toolkit is this organizational assessment tool, and it's really focused on an organization-wide approach to implementing TVIC through attention to organizational culture, policies, and procedures. I think Rachel gave a pretty good overview of kind of, why use the tool and what its purpose is. But really, the intention of this tool is to help identify how your organization understands the TVIC principles, to select realistic areas for improvement, and to evaluate your progress. And this tool is really meant to encourage and support open discussion about how to create a more positive environment for clients and also for staff. And so really, this tool was designed for any health or social service organization, but especially those that provide sexual health, harm reduction, or STBBI services. So though many of the questions are about sexual health, harm reduction, and STBBIs, being aware of the impact of stigma, trauma, and structural violence, and protecting clients from re-traumatization is really important for any health and social service setting. And the tool is designed to be completed by staff members who work in different capacities within your organization. So you would want to include management, intake workers, frontline service providers, and support staff, all different kind of sections of your organization in this process, because you might find that people who work in different areas of your organization have very different perspectives and perceptions of some of these things. So when we would recommend that this can be used as part of your organization's ongoing quality improvement process. And we're going to get into a little bit more on the next slide what the tool really assesses. But in terms of how it's designed to be used, we suggest that everyone kind of in this group in doing the assessment completes a form individually, and then you come together as a group to discuss your responses. And so the tool is going to require you to rate your agreement with 24 different statements, and it includes some space for you to write comments for each one. And it also includes a template sort of action plan to help your group plot out next steps once you've identified priorities for action. So for the purpose of today and with limited time, we're going to just kind of give you, again, we're going to use poll to show you a few items from the organizational assessment to kind of spark your interest and get you thinking about these things, but you're definitely encouraged to check out the entire organizational assessment, which has 24 different indicators. So I'll have you switch the slide there, Rachel, if you don't mind. And just kind of a high-level overview here. So the tool does include 5 different sections. These 24 different indicators are split up among supporting staff development, thinking about the physical environment where services are offered, relationships and interactions with clients, policies, and then monitoring and evaluation. And then, as mentioned, there's a rating scale that is applied to each statement. And really, there are no right or wrong answers. And again, your answer might really depend on your role within the organization and what you see in your day-to-day work. So we're going to walk through a few questions from the tool as a group, and we'll ask you to respond to each using the poll.
All right, so as Laura mentioned, we're going to share a poll that has 6 questions from the organizational assessment tool. I'll give you a few minutes to respond. If you're having trouble responding or kind of identifying your response for your organization, I just encourage you to go with your gut reaction. The purpose is not necessarily to identify the correct responses. Nobody will see your responses. It's really just to get you thinking about some potential areas for improvement, as well as the unique strengths in your organization. And again, once you've finished the poll, I do encourage you to share some things that you're doing within your organizations to integrate TVIC as it relates to some of the questions in the poll. So we'll just provide a few minutes while folks are responding. There are 6 questions, so I know it can take some time. And one thing I think in the interest of time, for each question, there are in the actual tool itself, there are different questions that you can use to sort of reflect and sort of consider where your organization might lie. So I do encourage you to take a look at the full tool. This is a very short snapshot, but there are 24 questions, and each question includes further questions for consideration that can really help you identify, areas for improvement, as well as areas where your organization is doing really well. Okay, so I'll just give you a minute or so, and I do see a comment in the chat from Kate, just to remark on COVID-19 has made most of these things challenging, and I certainly thank you for sharing that, Kate, and I certainly recognize that this tool, of course, was developed in a sort of pre-COVID world, and so some of the questions may not apply or just may not be within the realm of reality right now, and so part of the purpose of the tool is really to help you identify some of those easy wins. And so, truly identifying those steps you can take, even in the context of COVID, today, and then, some things might be more long-term in terms of larger changes. So I'm going to end the poll now. If you haven't had a chance to complete it, I do apologize, but as I said, we do encourage you to take a look at the full tool. Okay. So the first question, trauma and violence informed knowledge and skills are assessed during hiring, volunteer recruitment, and performance reviews. So, perhaps no surprise, there's a lot of diversity in terms of responses, and this might be a reflection of, working in different contexts or also working at different levels within organizations. The next question, potential for an impacts of vicarious trauma and minimized, and staff are supported to manage feelings. So I am happy to see that, a healthy majority of you are agreeing, but certainly that looks like there is some more work to be done. And I think that's, quite normal in terms of organizations across the country. The next question, really looking at the physical space and whether it's safe and supportive, and really thinking about, how clients or service users, patients might react to the sounds, the smells, the visuals within our service settings. And then the last question, question number 4, making sure that clients are involved in decision-making. And I think that's great. 55% of you are reporting strongly agree. And that's so important in terms of, giving back power and control to those accessing our services. Question number 5, there's a formal process to request input from current and or former clients. Again, a lot of diversity here, but a lot of you are reporting agree or strongly agree, and I think that's great. And that can be integrated, into the ways our services are organized so that folks can offer, feedback either confidentially or in a more open setting as well. And then the last one is making sure that our organization is accountable to adhering to TVIC policies. And I think, What we often find is that folks have policies that are reflective of TVIC, but sometimes there's not necessarily a mechanism in place to make sure that they are actually adhered to. So thank you so much, everyone, for sharing. As I said, I encourage you to share some things you're doing in the chat, and we'll make sure that this is shared with all of you after today's presentation. Okay. So in wrapping up, we did just want to share the link to this video, and it was created as part of our training on trauma and violence-informed care. And so in this video, we interviewed professionals from 4 different organizations in British Columbia, Manitoba, Quebec, and Nova Scotia to talk about some of the strategies they've used to integrate TVIC at an organizational level. So I would encourage you to take a look at the video because there are some really great strategies shared. And then lastly, so we had mentioned that there's 3 components of the toolkit. The last section of the toolkit pertains to monitoring and evaluation. And so this section summarizes different approaches and offers links to different resources that can be used to evaluate TVIC in service settings that cater to a really wide range of clients. So that includes those with as well as those without past or ongoing experiences of trauma. And so there are different approaches. Some of them are listed on the slide, and also for each of the approach, there are links to specific resources that you can take a look at if you'd really like to integrate TVIC into your work and think about how best to monitor and evaluate any changes you make at an organizational level. So with that, we have about 10 minutes left for questions. I really appreciate everyone joining today. And really for your engagement through the chat. I know I didn't get a chance to read every comment, and I'm certainly looking forward to going back and taking a better look at the comments. Both my email as well as Laura's email are on the screen. We do encourage you to get in contact with us if you have any questions. I believe Savannah has been sharing all the links that were shared on the slides, but we're more than happy to provide those once again if you have any trouble locating any of the resources we've chatted about today.
Thank you so much, Rachel and Laura. That was so much fantastic information in such a short time. It'd be really great to have you back to explore some more of that. We have a few questions, and if anybody else has any questions, please feel free to add them into the Q&A box. So the first one was, can you recommend a resource on grounding techniques?
That's a great question. I think that was something that we ourselves struggled a little bit too when we were pulling together resources for the training and for the toolkit. So definitely, I encourage folks if they know of any to share some in the chat. Offhand, I'm don't think we came across anything that we thought was particularly comprehensive or helpful. But I see some folks that maybe already started sharing some ideas in the chat. So that's fantastic.
Yeah, we can definitely share.
Yeah,
we can definitely share a few links, and I think there are certain. I see like Psychology Tools website or anxietycanada.com. Different websites offer sort of a compendium of grounding techniques that can be used both for yourself or as a professional. I do know that when we brought up the poll question, somebody brought up the sort of 5 senses activity, and that's something we do within our training. So either you as a grounding technique, or if you're working with service user or clients or patients, having folks think about 5 things that they see, 4 things that they hear, 3 things that they, et cetera, and kind of walking through each of the senses to help ground you in terms of your current environment. And so I see lots of amazing examples. So we again will spend some time going through the chat and then sharing with you all.
I'm really looking forward to pouring through some of these links. So thanks, everybody.
Right, our next question. This seems like a really great resource. Is it meant to be structured in a way that we can use it directly at work, or is there special training to implement it? You mentioned a 4-hour workshop. What kind of fees are there to bring your team in to offer this within our organization?
So in terms of the organizational assessment tool and the entirety of the toolkit, it is available, and there are instructions throughout it to sort of help you integrate it into or use it within your practice or within your organizations. I think as Laura mentioned, it's meant to be sort of completed individually, and then folks from the organization would come together to discuss responses or common reflections, or to discuss maybe where there were differences in opinion in terms of how well the organization is doing. So that's sort of the organizational assessment tool and the complementary self-reflection tool and the sort of piece on monitoring and evaluation. In relation to the training itself, so because we're a national organization, we don't necessarily offer training to individual organizations or professionals across the country. However, all of the materials are available in a turnkey format, so that if you sort of are accustomed to providing education and training or professional development to health and social service professionals, you could certainly use all of the turnkey tools to deliver the training in your community. And certainly questions from the self-reflection tool, as well as questions from the organizational assessment tool. A lot of what we've chatted about today are integrated right into the training. So it is available free of charge. In terms of actually accessing it, we do ask that groups go through a very short online course just so they understand sort of how it should be used in your community. But the training and all the materials you would need to deliver the training are available. In terms of support, though, we're happy to chat with you about, walking through the different workshop materials and thinking through, how it might look in your community. So I would say definitely reach out to us if you are interested in having this training brought to your community, because I think that's something that we're, the intent was to get it into the hands of as many people as possible.
Perfect. Next question. Does your organization have any adaptations to this training that could be Indigenous focused, or is there an ability for people delivering the training to take some liberties to make it Indigenous specific to fit the needs of the communities?
Yeah, certainly. So as Rachel mentioned, the tool was kind of designed and developed in a turnkey format with the expectation that folks in different communities and working, in different contexts would be able to actually use and deliver the training. And with that, of course, also does come, potential needs for adaptation. And I think particularly, like adaptations for an Indigenous specific training would be, really important to do to take this workshop and use it forward. So I think that's definitely something that we would be really interested to hear more about. You could certainly connect with us if that's something that you're interested in working on, and we're happy to kind of help with logistic support around, using and adapting the training tools. But yeah, I don't know if you want to add on to that at all, Rachel.
No, I think the intent, like Laura said, was always that, there would be adaptations made either so that they were more community specific or cultural adaptations. So, do be in touch with us if you're interested in offering a training to different communities and sort of chatting through some of the adaptations. I think that's great. And certainly was always the intent.
Perfect. I see a recommendation for a book as well in the chat. Decolonizing Trauma Work, Indigenous Stories and Strategies by Renee Linklater. So that's also a resource that you can maybe consult in the meantime.
Yeah, it's a great book. Thanks for sharing, Beverly.
Perfect. Let's see. Maybe a couple more questions if we have time for that. So when you are hiring potential employees, do you train them to your expectations, or do you expect them to have the acquired knowledge beforehand other than the basic requirements? And I presume this is related to TVIC.
I don't know that. Yeah, so I don't know that there's a sort of right or wrong answer to this question. I think it would really depend on sort of the nature of the role, as well as the nature of your organization. I think within the toolkit, however, there is a question around, is TVIC integrated into hiring practices? So knowing beforehand whether or not folks have experience, as well as, further training on trauma and violence informed care. And if not, making sure that that is a part of sort of onboarding folks, so that it's not just that, they come on and then maybe after a year of being at your organization, they're participating in training, really making sure that it's a priority from the minute that somebody starts at your organization. So I think in terms of, whether you train them or whether you're only hiring potential employees with that sort of knowledge and experience would really depend on the nature of the role and the organization. But by and large, I think just making sure that TVIC is prioritized for all staff, including frontline folks as well as non-frontline folks.
And it kind of, again, comes down to that being kind of an integral part of the organizational culture.
Perfect. As a last question, it's one of mine that I've been wondering, but do you have any recommendations for individual professionals who maybe work at an organization that's resistant to take this perspective on and do the work and the training that's necessary in order to center it in their practice? And this can also be related to organizations that say that they value this approach but don't necessarily implement it. It's can be tricky, I think, for individuals on how to advocate for this.
So this is a concern that has obviously came up a lot when we were pilot testing the training on TVIC, from professionals that were participating, saying I work within an organization that's not supportive of this approach, or there's competing priorities. I will say we did hear from quite a few folks that the organizational assessment tool can be really helpful to identify those sort of small wins and then perhaps use that to broker a conversation with management. Because sometimes it's a matter of you don't know what you don't know. So we might think that our organizational policies and practices are in line with TVIC. But then when you actually take the time to sort of think about the patient journey and all the areas that our services are inherently created to sort of disempower folks, we can kind of sort of quickly identify where improvements need to be made. So I think that can be a really great tool to help broker that conversation with management.
Perfect. Thank you so much. Did you have any last things that you would like to share with everybody?
No,
I just like, oh, sorry.
Go ahead, Laura.
I just like to say thanks so much for everyone for being so engaged. I know we invited a lot of interactivity in the workshop, and I feel like I've learned a lot from the insights that you folks have shared, and I'm really looking forward to going back through and reading the chat. So just thank you so much.
Yeah, likewise. Thank you, everyone. And I know we shared a lot of information, and so apologize. I know that Laura and I were speaking quickly at times, and because we had so much information
with
to
our
share.
eye on the clock.
So thank you for your patience with us. And I would just echo, if you're interested in the training or any of the tools, please do get in touch with us. And it's always exciting to have those conversations and see the tools actually being used in different parts of the country.
Perfect. Thank you so much for this great and informative presentation and sharing these tools with everybody. It's been a great learning experience. Just want to remind everyone that I will be sharing the links and the slides along with a recording and a follow-up email. So you'll be able to check all of this out in your own time so that we, can get this rolling and incorporate it into our own work. So I would also like to let everybody know that when you leave this meeting, you'll be directed to an evaluation link. Completing these evaluations helps us determine the focus and format of our programming and allows us to better support everyone here as professionals in this work. Once again, a very warm thank you to our speakers today, Rachel McLean and Laura Bouchard from the CPHA, for sharing their knowledge and work with us today. And thank you to everybody who attended this webinar. Have a wonderful day.
Thank you, Savannah, for organizing.
Yeah, thank you.